Welcome to another episode of the AUA University podcast. I'm Dr. Mark Gonzalgo, Professor of Urology at the University of Miami and Chair of the AUA Office of Education. Today we're taking on a topic that's generating enormous interest across urology, the role of artificial intelligence in prostate cancer treatment planning. AI is already influencing how we interpret imaging, pathology, and risk, but translating that into promise, into tools that actually improve decision-making at the bedside is where things get interesting. Today, we'll focus less on hype and more on how AI can meaningfully support real clinical decisions, from focal therapy planning to risk stratification and treatment intensification. I'm delighted to be joined today by Dr. Wayne Brisbane, Assistant Professor of Urology at UCLA, and a urologic oncologist whose work sits at the intersection of prostate cancer care, advanced imaging, and AI-driven decision support. Wayne, thanks for being here today.
Thanks so much for having me. It's something I'm really looking forward to.
And we as well, we appreciate it so much. And let's just jump right into it. Urologists today already try to synthesize in part, concepts and variables such as MRI, biopsy results, PSA, and a patient's overall clinical picture. So why is it so important that AI mirrors this type of multimodal approach?
Yeah, so specifically in my small sphere, I'm thinking about AI within prostate cancer, which is my research interest and also my clinical interest. And I think a lot of us as urologists, we already do this to some extent. If you think about NCCN and risk classifications, that's taking multiple modalities like PSA, your stage just based on your digital rectal exam, your Gleason score, and using those features to help risk stratify men. And I think we also intuitively can say, if there's a big lesion on MRI and you just have 3+3, maybe that's you're skeptical that patient doesn't fit in the low risk category. And so all these things that we're intuitively doing can be quantified a little bit better through machine learning and AI and to help us kind of also bring in some of the nuance for these continuous variables. And so I think it's things that we're already doing, but we can standardize it and make it more consistent.
Great. One concrete example is something I know you've been quite involved with, and we're really looking forward to hearing about it, is Unfold AI, right? Can you explain how integrating MRI, biopsy, all these features we see, correlation, pathology, and clinical features allows AI to generate this type of patient-specific 3D tumor maps I've heard about, and why it might matter for treatments such as focal therapy?
Sure. So Unfold AI is a technology that was spun out of UCLA, and its specific goal was to try and predict the extent of tumor within the prostate. And so, prostate MRI is a fantastic tool. We've been using it now for up to a decade, but it tends to underestimate tumor volume. And that can be very important for people for gentlemen who are seeking focal therapy. But it's also important for basically every stratification within prostate cancer. So, our radiation therapy colleagues will try and boost the MRI visible lesion. That was with the FLAME and HypoFLAME trials, which showed that can lead to better cancer outcomes. And then obviously people or surgeons who are trying to predict exactly the extent of tumor and specifically capsular involvement need to know tumor volumetrics. So tumor volume is super important. And up to this point, MRI was probably our best detection of tumor volume, but by adding in biopsy cores, we could kind of refine that. So for example, you'd have your targeted cores and then maybe your systematic cores were in the region of the ROI were also positive. So you'd know that the tumor was bigger than just the ROI. But it was hard to do that in a consistent manner and actually come up with a tumor map that you could use for treatment. And that's what Unfold AI was designed to do. It was reproducibly predict tumor extent within the prostate based on the MRI, biopsies, Gleason score, and then PSA and age. And so it takes in those multimodal inputs and gives you basically a heat map of where the cancer should be.
You've also done some important work with a technology that I'm sure some of the audience have heard of, and that's called micro ultrasound. How does high resolution real-time imaging complement MRI, and how do you see this type of technology fitting into future AI models?
Yeah. So, Unfold AI is probably, is taking existing technologies and trying to, like MRI and biopsy, and trying to get a novel output of tumor volume. Micro ultrasound is a high resolution ultrasound. It feels somewhat like ultrasound. It's all in the sagittal plane, so it looks slightly different, but it's urologist driven, and it can be very, very high resolution imaging. And the Optimum trial, which just shows urologist interpretation versus kind of the conventional MRI path, demonstrated equivalency of detection of clinically significant prostate cancer. So it's a really powerful tool. But one of the drawbacks is it's complicated to interpret. And especially, for urology workflow, we're doing the interpretation at the time of biopsy. And so it's kind of, you have the probe in the rectum, and it's quite difficult to, or it's more cognitively high stakes than just like in a dark room with a coffee, flipping through MRI images. And so it's a good place where kind of an AI aid can come in and show us hotspots, and we can then go through and take a look and either say, yeah, that deserves a biopsy, or no. It's in a little bit earlier form than our work with Unfold AI, but I think another kind of good demonstration of where AI can help us.
You just briefly mentioned something that I feel is important that we keep in mind as we continue to learn more and develop AI tools in our workflow. And that's really the importance of us, right? Humans and urologists, in not only planning, but interpreting and seeing this forward in the proper way. And one of the recurring issues in AI development is that models, for example, are often trained on convenient surrogate endpoints like PIRAD scores, rather than outcomes that might actually be more important. From your perspective, what endpoints should we as urologists be insisting on as, we try to reframe AI in the future use?
Yeah, I think it's a really good point, and kind of a lesson I learned through my work with Unfold AI and then also in micro ultrasound. So I do think that when we're as urologists trying to work with AI scientists to come up with these models and tools, we should remember that we have a lot to contribute. And one of the things that we can contribute are figuring out what are biologically important endpoints or patient-centric endpoints that matter. And the example that you gave was a really good one. For example, if you're trying to train an algorithm to identify PIRAD scores, that's a lot less powerful than trying to define like metastasis in over 5 years. So one is just some like artificial construct that we've come up with would be the PIRAD score. The other is really biologically driven, which is, how aggressive that tumor is expected to be. And the story that kind of helped me figure this out is when we were training Unfold AI, we were training it not to predict something like Gleason score. We were training it to predict tumor volume. And that's what it was meant to do. And it worked well. But then we went on to see, does it predict extracapsular extension and seminal vesicle invasion? And it did a really good job with those things as well. So it really taught me that as a urologist and definitely as a researcher in this area, if we try and define biologically significant endpoints, tumor volume just kind of happened to be lucky, the models will predict other things that have underpinnings within the same area. And so I think that that's a really nice way to kind of remember that these models, usually when you go to a different application, they lose their accuracy. But if we really focus on biologically driven endpoints, they can still have potential to have considerable accuracy beyond where we train them.
That's a great point. And, this brings up, I think, another example that some of the audience may or may not have heard about. And that's the example I know you've had experience with Artera AI, which is something, platform that integrates digital pathology and clinical data to predict long-term outcomes like distant metastases and prostate cancer-specific mortality. How did this change conversations around active surveillance versus treatment intensification?
Yeah, so Artera, I think, is a really probably the best example of how clinicians who are careful and thoughtful can really reshape the tools that we use every day. So specifically, we have to really tip our hat to the NRG as a institution or as a collaborative group of radiation oncologists who are building these clinical trials. And then obviously Felix Fing, who is really the visionary behind this, and Dan Spratt and others who have said, hey, you know what, we can use these clinical trial outcomes and then retrospectively train AI and then prospectively apply it. But so Artera is basically, they took all these old, not super old, but these old NRG radiation trials, they digitized the pathology, and then they used those digital pathology to train against metastasis-free survival. And so now this is something that was able to pretty rapidly get into the NCCN guidelines. And so I think the takeaways for urologists are threefold. A, remember, anytime you want to work with AI, the input has to be digitized. And so you got to think about, like, how can I take the information that I want to work with? And if that's patient-related outcomes, do we have to develop a new survey to digitize those kind of leakage or sexual endpoints? Or do we need to digitize pathology? How do we get the images over to an AI? And then how do we also, how do we make that meaningful as far as an input? So everything has to be digitized in order to make it work. I think that's pretty intuitive, but it's an important thing to remember. And the NRG had to overcome that kind of headache. As a quick aside, as a story, when I was working with Felix a while back, Felix eventually passed, but it was really instrumental in building this vision for kind of AI to predict cancer outcomes. We tried to consider integrating the planning CTs. So they had digital pathology, but we thought we should integrate the planning CTs because that would be useful as well. And unfortunately, the planning CTs, they just hadn't been digitized in a way that could allow them to be fed into the AI. And that seems silly, but it was a major hurdle to overcome and eventually couldn't be used. So that brings up the second point. For those of us who are interested in doing this kind of work and have the opportunity to design clinical trials, on the front end, we should be designing the consents for our clinical trials and the digitization of those inputs prospectively with the thought that AI could be involved. And the real key here, at least in our institution, has been remembering that if we consent the patients to share their data for AI development, that will be very useful when we go back and try and do this in the future. And then the third thing is just a reiteration of those, really focus on those biological endpoints for large clinical trials. I think we're all used to doing this, kind of metastasis-free survival, but the more creative we can get on making sure that those endpoints really are meaningful to us and our patients, I think it'll help us in the end.
That's great. And you mentioned something about how we need to maybe shift gears and think about this prospectively in almost anything we do. And wanted to focus now on how we can translate AI, into the real world, because even the best AI model is irrelevant if it never reaches and impacts patient care. As you mentioned, you've worked both in what we consider to be open science and commercial pathways. Can you walk us through the strengths of each?
Yeah, certainly. So I've kind of done AI research in a couple of different ways, and I think that you're absolutely right. So it's frustrating when you see a lot of these algorithms get published and then never really be able to be implemented in clinical practice. So as it stands now that I'm aware of, there's really two pathways to getting your work out there. One is through conventional open science, which I think is really good way to do it. And again, one of the things we've had to work with is really prospectively consenting our patients to AI development. And most patients are very open to it. But this would be like publishing your data on open source platforms so they can be used to develop things. So for example, there's the government will host your data or your imaging data, for example, free of charge. There's multiple other platforms for this. So we put a lot of our micro ultrasound images up there to help get people interested in AI research with micro ultrasound. And then the other thing is, publishing your algorithms in a way that it's kind of this open source movement that a lot of us are familiar with, both publishing our code and publishing the data sets. Again, just going back to point one, you really have to prospectively think about this, because if you try to do this retrospectively, your institution will be very incentivized to hold on to that data. So it can be tricky. So thinking about it from the front end and making sure you consent your patients to say, is it okay if I use your data for AI development, not only here but elsewhere as well.
Right. And on the other hand, Unfold AI went through commercialization, right, and regulatory approval processes. Why is that pathway essential for things like scalability and real world impact?
Yeah. The other thing that I think is important is sometimes commercialization can be the fastest path to clinical acceptance. We have a pretty good method of getting particular software or particular tools to be paid for by insurance remuneration. And so if you really have a great idea and you think that it should be out there, sometimes incorporation or selling the idea to a commercial interest can be a very effective way to go about this. So in my AI work with imaging, I've tended to do a little bit more open science, and some in my AI work with this particular Unfold AI company, which I don't receive any money from, but it was commercialized through the UCLA kind of entrepreneurial route.
What lessons would you say you've learned about thinking early about deployment strategies when you're trying to develop AI for practical use?
Yeah, I think for the main lessons that I've learned have been those three that I've discussed. Think about things as they need to be digitized. It seems super intuitive, but it can trip people up. The second is really use your prospective clinical trials as an opportunity to think about what you would like to build in AI going forward, and also incorporate that into the prospective consenting of patients. And then the final thing is use to the best of our abilities biologic endpoints that really matter, because that helps extend the AI's outcomes beyond the just initial training. And then all the things that we learn just doing good science still apply, multi-institutional validation, making sure that we have good quality of data in, and high levels of validation are important.
Great. Wayne, we wanted to try to focus perhaps on some clinical dilemmas and practical integration and bring this back to the clinic. So I want to ask you the question of, where do you see AI adding the most immediate value today? Is it diagnosis, focal therapy planning, risk stratification, or treatment selection, or anything else?
Yeah, so where I'm using it the most right now is in the diagnostic space. That's mostly where my research is necessarily kind of predicting who has cancer, and then what do we do about it. So I think I see a lot of potential in the diagnostic space currently. We'll see things in the risk stratification, because I think that good diagnostics also bleeds easily into risk stratification. And as we get, these clinical trials that help us decide who's the best candidate for certain real world treatments, we can use AI to help us predict or help us decide who those patients should go get treatment with. For example, we used Unfold AI to look at the last 200 patients we had treated with focal therapy and help us predict success based on tumor volumetrics, and found very nicely that tumor volume was a high predictor of ablation success. And it's pretty intuitive, but we're able to quantify the values that really started to show a decrease in success. And then we can obviously prospectively validate that. So I think that those are the kind of places where we should see some benefits.
Great. When you talk about new ideas, there are always potential barriers to adoption. What do you think are the most common reasons we as urologists may hesitate to adopt AI tools? And how might we begin to address these types of concerns?
Yeah, so I think one of the, real practical obstacles is we've just seen such an explosion of AI tools. It's hard to know a little bit which ones to use. And then all of them at this current era have some significant costs associated with them. So what I find is most of us are trying to figure out, even within our regulatory environments, and just kind of which ones are the most useful. And I think that's a real issue. The main things the main things that I use to help me make the decision. I'm not an expert in actually deciding between AI tools, just developing some interesting ones. has been the same things that we use to decide all the kinds of tools. Like, how do you make a decision between, your different PSA tests, or 4K versus ISO PSA versus ExoDX, or Decipher versus Oncotype. And it's going to be going back to seeing how they were developed, how are they validated, and things like that. I think if you just think of AI as a specialized software tool, it kind of loses its luster, and you can think critically about what might work.
That's great and very valid points. And I think as we begin to wrap up, you've highlighted some key points for us to follow when we're beginning to even try to get our hands on using AI in practice. But what would you say is the bottom line for urologists who are thinking about AI in prostate cancer care?
Yeah, I think it's definitely I think the bottom line is it's definitely on the NCCN guidelines now. So it's at the level of reaching high quality evidence prospectively to help us inform our patient care. And that's with Artera, at least at the very entrance. And then you have all these other AIs like Unfold AI that have some ability to help us predict who might be a good candidate for focal therapy, or within radiation and surgery, help us expand our radiation or predict ECE. And then I think pretty reasonably quickly, you're going to have, we already see, MRI diagnostics. So you have, a lot of us will see, an AI read that has picked up a lot of lesions on MRI. So we'll start to see things like that. And then I think, I'm not entirely sure to what extent our robots will integrate AI, but that sure seems to be on the future, at least with Intuitive. Again, this is me just kind of with conjecture at this point, but you'll start to see, I would imagine, these sort of things. And then also there's a lot of, AI companies looking at drug development. So trying to predict drugs that will be, targeted to certain receptors. And so I'm hopeful that we will start to notice more efficacious drugs with fewer side effects that can really have novel targets within prostate cancer for really advanced disease.
That's a great final closing points. And, Dr. Brisbane, thank you for an outstanding discussion for this podcast. You've really made it clear that AI's future in prostate cancer isn't about replacing clinical judgment. It's about amplifying it. And when we as urologists stay actively engaged in shaping these tools, hopefully we can continue to make and improve our impact on better patient care. For more educational content, please visit auanet.org/university. And to our listeners, thank you for joining us. I'm Dr. Mark Gonzalgo, and we look forward to bringing you another episode of AUA University Podcast.